Osteoporosis affects both genders, and certainly the prevalence of it is as common in Caucasians, Hispanics, Asians, a little bit lower in African Americans. A lot of physicians don't recognize the fact that a wrist fracture or spine fracture, even asymptomatic after the age of 50, puts a person at high risk. If we're going to conquer this disease at a population level, it's got to be at the hands of the family physician and the internist. And one of the struggles there is the fact that bone densitometry availability and accessibility is going down.
I'm going to scoot you down just a little bit towards your feet. So I'm going to start off by doing your hip first.
Okay.
And so for your hip, I have a positioner that I'm going to just put between your feet.
I was having quite a bit of pain on the lower back, and I noticed that whenever I knelt down, to do something on the floor for extended period of time, it was difficult trying to get back up. And so March of 1991 was when I had my appointment with Dr. Miller. And at that time, it came up with a diagnosis of osteoporosis.
About 20% of women living to 90 will have a hip fracture. About 16% of men living to that age will have a hip fracture. And the interesting thing about the data is that the one-year mortality rate is about 20% will die within the first year from complications surrounding the hip fracture. It's about 30% in men. Male osteoporosis is a very important condition. So much so that a few years ago, the NIH funded a large 10-year prospective study called Mr. Os to take a look at risk factors and other interactions for this growing problem of osteoporosis in men. The main risk factors are a family history of a hip fracture in mother or father. That's one of the big ones. Being postmenopausal, not on any hormonal replacement therapy. A prior low trauma fracture after the age of 50 years. Falling down and having a wrist fracture, or having a vertebral fracture. Smoking, heavy alcohol consumption chronically. Taking prednisone, steroids for different diseases that are required, like asthma or lupus.
When they did the surgery on my back.
Mr. Jerome Hills, rheumatoid arthritis. When he first came to me, he came to me with 6 vertebral compression fractures.
In 2002, the rheumatologist at that time told me that she wanted to cut the prednisone down because it's bad for your bones. And so we started cutting back.
Prednisone decreases bone formation and decreases remodeling. It's an inhibitor of osteoblasts. The effect of glucocorticoids is dose-related and duration-related. So if someone's on, for example, 60 milligrams of prednisone a day, and they can't decrease that dose, within a year, a large proportion, it might be as close as 50%, may be expected to fracture.
When you start getting down into the single digits on the prednisone, you have to decrease them real gradual, which means that I can only do 1 milligram every 2 months. And eventually I hope to get to 0. Yeah, you're trying to balance your pain level with the prednisone.
If they're on 2.5 milligrams a day, tiny little doses, but they're on it long enough, it'll increase the risk of fractures as compared to somebody who doesn't take any. So as necessary as glucocorticoids are for many diseases, that group of patients have to be watched much more carefully.
Hi, my name is Kelvin, and I work on the team that creates the content that you've just seen, MedscapeTV. If you like the content and want to see more, click click on the button to the right and it'll take you to the full series.